Hey study buddy, this is your local 4th year med student Eli Chen, and welcome to Pre-Rounds, where we'll talk through a case, review some high-yield topics for exams, and hopefully become a little less confused together. This is the Step 1 version of the case, where the information is geared towards that exam in particular. Check out the Step 2 version of this case if you're prepping for that instead. And lastly, I'm not a real doctor yet, so all the infos and sources are taken from the real doctors and their guidelines listed in the description. Also, a disclosure, all of this information is for the purpose of education and none of this should be taken as medical advice. So let's get started with our case. It's an 82-year-old male with burning while peeing for 3 days. Did he accidentally get hit with a soccer ball? Or did he try to get frisky in the nursing home? I don't know. Let's find out. Also, this case is pretty simplified from the Step 2 version because otherwise it'd get way too long. So make sure you check out the Step 2 version for added complexity. So let's get a little bit more of his history. So his burning while peeing started 3 days ago. He still feels a strong urge to go, but he can usually make it to the bathroom. He's also peeing more often and overnight a couple of times, but this frequency overnight has been happening for a couple of years now. He has had a history of dribbling while peeing, difficulty starting his stream, and feeling like he's not emptying completely. He doesn't have any blood in his urine, but sometimes a tinge of pink. He doesn't have any discharge. Sometimes he has some pain in his lower belly. He doesn't have any fevers or chills and no nausea or vomiting, and he is not currently sexually active. So let's translate a little bit from symptom to medical term. So this burning and pain while peeing is called dysuria, and it usually means there's some kind of irritant in the urinary tract. Peeing more often is related to frequency. This could also be due to irritants, but it could be also due to a lot of things. Polyuria is too much in total volume, which is over 2.5 liters of urine. In this case, he's dribbling and not having a lot of volume, which could indicate incomplete emptying. Blood in the urine is referred to as hematuria. And there's two big groups. One of them is gross hematuria, which kind of looks like a Bloody Mary, maybe with fewer chunks, I hope. And the other group is microscopic, which is only a couple of red blood cells found on urinalysis. And in this case, he may have some microscopic hematuria, but we'll be able to access this when we get a urinalysis. The feeling that you can't resist the urge to go is referred to as urgency, but the fact that he can make it to the bathroom indicates to us that he doesn't have any incontinence or loss of urinary control. The pain in his lower belly is referred to as suprapubic pain, and in exams it's indicative of bladder distension and irritation. His symptoms indicate a pretty classic picture of a UTI, with the three main symptoms being dysuria, frequency, and urgency. And this collection of symptoms, including peeing multiple times overnight, dribbling, difficulty starting a stream, and incomplete emptying, paints a picture of chronic obstruction, likely due to benign prostatic hyperplasia. This chronic obstruction would require more force to push past. It's kind of like drinking water from a boba straw versus like a coffee stirrer. It's easier to sip from the boba straw because it's wider. In a patient who is an older male like him, I would suspect benign prostatic hyperplasia as being the cause. So let's get a little bit more history. On a review of systems, he doesn't have any weight loss or fever or chills. He doesn't have any chest pain or palpitations. There's no coughing, wheezing, or dyspnea. And as previously stated, no nausea or vomiting. He does have dysuria and increased frequency and urgency, and he doesn't have any confusion. For past medical history, he has BPH, benign prostatic hyperplasia, hyperlipidemia, and hypertension. For relevant social history, he smoked for 20 years, half a pack a day, so that's 10 pack years because a pack year is 1 pack per day. But he quit 15 years ago. He doesn't drink any alcohol or do any recreational drugs. His medications are tamsulosin, lisinopril, and atorvastatin. On physical exam, he's alert and well-appearing. His pupils are equal and reactive. He has a regular rate and rhythm, no murmurs or rubs or gallops. His lungs are clear to auscultation bilaterally. He has a soft, non-distended abdomen. He does have suprapubic pain and a mass. He has normal bowel sounds and no CVA tenderness. His skin is warm and dry. His pulses are equal in all extremities, and he is alert and oriented times 4. So the diagnosis here would be a UTI or urinary tract infection, in this case cystitis. This is diagnosed by the dysuria, frequency, and urgency, which are classic symptoms, and we're also going to get labs to work this up. You can also diagnose this just based on the symptoms, so those on telehealth can get antibiotics as treatment just by video chatting. Other diagnoses on the differential include an STI urethritis from either chlamydia or Neisseria gonorrhea, but this is less likely due to the lack of discharge and no sexual activity. Pyelonephritis is on the differential because you want to know how far up the infection goes, but it's less likely because he doesn't have fever or chills or CVA tenderness. And any painless hematuria in an elderly person, especially with a smoking history, he smoked for about 10 pack years, gets cancer on the differential, and in this case, bladder cancer. But it's also low on the differential because there's no fever, chills, or weight loss, and this collection of symptoms is pretty acute in presentation. So risk factors for UTIs, it happens 10 times more often in females due to the urethra being shorter, and it's closer to the fecal flora than males. And there's a couple of categories that would increase the risk for UTIs in terms of pathophysiology. One of them is reduced flow. So this would be like why you shouldn't drink stagnant water in nature. It breeds bacteria and algae and maybe some mosquito eggs you don't want to drink. And in humans, outflow obstruction due to BPH, prostate cancer, or pelvic organ prolapse can cause reduced flow. Other causes of reduced flow include neurogenic bladder and dehydration. There's also a category of introducing more colonization, and this is via sex, spermicides, low estrogen in cases of menopause, a foreign body, or repeated catheterization. Another disease process that would be high risk of colonization is having glucose in the urine. So this would be diabetes or any drugs that induce glucoseuria like SGLT2 inhibitors that also have UTIs as a side effect. And lastly, there are congenital risk factors like vesicoureteral reflux. So what are the common bugs that cause UTIs? E. coli is by far the most common. Second most common is Staphylococcus saprophyticus, which is usually in sexually active females. Third is Klebsiella pneumoniae. And there's also other bugs including Serratio marcescens, and it actually forms a red pigment. And I found out recently that it's the stuff growing on my shower tiles because it's an airborne bacteria with spores that float through the air and forms a biofilm. But I remember that it's red because the tiles turn pinkish. And Enterococcus can also cause UTIs. This is usually from colon bacteria exposure. So getting more into the clinical aspect, there's a couple of flavors of UTIs, and this would be more important when determining disposition and treatment. When the patient doesn't have any symptoms, but on urinalysis, the nitrites and leukocyte esterase are positive, this is an asymptomatic bacteriuria, and we don't generally treat this unless they're pregnant. For uncomplicated UTIs, they have to be immunocompetent, not have any urologic abnormalities, not be pregnant, and be a woman. So basically only young females with no weird anatomy can be considered to have an uncomplicated UTI. Complicated UTIs include anybody who is postmenopausal, pregnant, a man, immunocompromised, or have any urologic abnormalities. Pyelonephritis is usually indicated with CVA tenderness and fever and chills, some systemic symptoms. And urosepsis is sepsis criteria and bacteremia due to UTI. So this would have positive blood cultures as a result of the UTI. So what kind of labs do we want? We definitely want a urinalysis, and this would show leukocyte esterase and or nitrates positive. So leukocyte esterase is an enzyme from the neutrophils released due to infection. So nitrates are present in gram-negative bacteria, so it's really helpful with E. coli being the most common bug. And it's pretty specific, but it would not appear positive with gram-positive bacteria like Staphylococcus saprophyticus. After the urinalysis, we'll get a urine microscopy, which would show more than 10 white blood cells. And this test is sensitive for UTIs. When the microscopy shows more than 10 white blood cells, but the culture is negative, this is called sterile pyuria. And this can occur with urethritis due to chlamydia trachomatis or Neisseria gonorrhea because they are both intracellular bacteria. And we also want to check for squamous epithelial cells. Over 20 indicates a contaminated specimen, and the bacteria obtained may not be from the bladder. So anatomy-wise, as we get further to the outside world, the urethra epithelium turns from transitional cell around the bladder to pseudostratified columnar to squamous for males. And for females, the transition is quicker. So when we have squamous epithelial cells, which are mostly from the outside, we're concerned about contamination from the outside. And on urine culture, we would expect over 100,000 colonies per microliter. And we can use this to obtain the bacteria and sensitivities for treatment if the standard antibiotics aren't working. So let's go back and work up this patient. So we got a CBC and CMP. Both of them are largely normal, and the white blood cell count is also normal at 10,000. And this is important because we want to rule out that he has any kind of sepsis or pyelonephritis. His urinalysis shows dark, yellow, and cloudy urine. His pH is 6.5. His glucose is negative. He has 1+ protein, many bacteria, and 3+ leukocyte esterase, but no blood. Urine microscopy shows over 10 white blood cells, nitrate positive, red blood cells less than 5, epithelial cells less than 5, no CAS, and specific gravity of 1.015 or 1015, which is a little bit higher than normal, which is around 1010. And as true to the timing of real world, urine culture is pending. So because he has that suprapubic mass, I'm concerned about bladder distension and retention, so let's get a bladder ultrasound. This shows 350 milliliters in the bladder, but no hydronephrosis. Bladder ultrasounds are more useful as a post-void residual, as in after you pee, how much are you retaining? But in this case, we at least see his bladder is somewhat distended, and it hasn't gone up to the kidneys. We can try to ask him to pee again, and if it still comes back around 300, we can think about how to relieve the obstruction, either with a Foley or catheterization. But basically, this just shows mild retention from BPH. I'm not worried about the kidneys right now because the CMP was normal, which includes the creatinine and BUN. So, to sum this up, this is an 82-year-old male with a relevant history of BPH, presenting with dysuria for 3 days due to a UTI. So our categorization for a UTI is complicated cystitis because he is a male. Our plan for this is ciprofloxacin, which is a fluoroquinolone, for about 1 to 2 weeks. That's typically the treatment for complicated cystitis. We'll follow up with a urine culture and sensitivities to check for antibiotic sensitivity. And because he has BPH and he's on a medication for it, he should have a urologist who's managing his BPH. And so we would suggest to follow up with urology to make sure those symptoms are managed and he doesn't get recurrent UTIs. So the last section of the episode is curiosities and conundrums. And this episode's rabbit hole is looking at the possible myth that cranberry juice prevents UTIs. So the idea comes from the fact that cranberry juice has a lot of proanthocyanidins, PACs, that inhibit the adherence of the E. coli fimbriae to the urothelial cells on the bladder. Kind of like lubing up a slip and slide with butter to make sure you go faster. So one systematic review in 2023 saw that randomized control trials demonstrated that cranberry products reduce the risk of UTIs in women with recurrent UTIs, children, and people at high risk due to a medical intervention. In treatment, another systematic review notes that no randomized controlled trial showed that it was good at treating UTIs. So let's stick with antibiotics as treatment, but cranberry products could definitely be used as a prevention strategy. And the evidence quality in terms of sample size and consistency were too low to determine whether cranberry juice or tablets were better. And additionally, PAC doses are hard to calculate. There's a couple of studies showing that they tested a dose between 1.4 milligrams to 120 milligrams a day, and there's a double-blinded randomized controlled trial in 2021 that demonstrates that a high dose above 36 milligrams is required to have an effect, which could be about 300 milliliters or 10 ounces of cranberry juice. Also, the dose in cranberry products is very hard to determine. Volume does not always equal the amount of PACs, and concentration vary with individual products, and some cranberry juices don't have PACs at all. But generally, pills are going to be much more concentrated than juice. It's hard to convert, but the studies had volumes of 30 milliliters to 1 liter of juice a day, which is probably more liquid than I drink total a day. And there's one private practice urology place that says a capsule is equal to 28 ounces of juice, which is a little more than a venti, or a large size for those of us not fluent in Starbies. And this is an aside. In an aside, even though venti means 20 in Italian, it's 24 ounces for cold drinks at Starbucks, probably accounting for the ice, and 20 ounces for hot drinks. And so the studies have tested between 1 and 4 tablets a day. So basically that would be like a metric ton of cranberry juice if you're trying to only do it in juice form. So ultimately, it seems like cranberry products help prevent UTIs in high-risk people, but it's probably got to be a lot of cranberry. So capsules are your best bet. So to recap our teaching points, we covered UTI symptoms, risk factors, and our diagnostic workup. And we also talked about the escalation of UTI symptoms and management from cystitis to pyelonephritis to sepsis. So that wraps up our case for now. Feel free to check out our other cases on the podcast in the meantime. Drop a comment to let us know how we're doing, and next time you pass by your friend who's always a tad bit too stressed, give them some water. Support your 3-drink girlies. 1 drink is for caffeine, 1 for hydration, and 1's for funsies. Alright, see you in the next one.